Recording stopped.
I'll tell you what I want after the meeting. Yeah.
I don't know. Oh no, he's on the tourism.
Bấm phê. Ông mua rồi.
Recording in progress. Recording stopped.
The House Chairperson.
Recording in progress.
There will now be an opportunity for silent prayer or meditation. Please be seated. The Secretary will read the order of the day.
Debate on vote number 18, Health Appropriation Bill.
I now invite the Honourable Minister of Health to deliver the budget speech. Please correct the time for the Minister. His time is up already before he has said a word. Yes, just keep the time accurate as well. Do you have an alternative mechanism to keep time? Yes. The NA table staff has been found wanting. Okay, Honourable Minister, they will have an alternative device here and we'll alert you when you have a minute left. You have 15 minutes to make your input, Honourable Minister.
Eddie?
Thank you for your understanding. We don't want to delay proceedings any
Okay.
longer. Thank you.
Honorable House Chair, my colleague, Deputy Minister of Health, Dr. Joe Patla, Chairperson of the Portfolio Committee on Health, Ms. Faith Mutambi, and members of your committee, heads of public entities, honorable members of the House, it's a privilege to present to you the 2026-27 budget for the National Department of Health. In the State of the Nation address, by President Ramaphosa in February this year, he announced 3 very important programs that the Department of Health must unfold this very year. And let me quote him. He said, "We are working to build a healthy nation as part of preparation for the national health insurance. We are investing in health facilities, personnel, and systems to improve access to quality healthcare. We'll be undertaking substantial investment in health infrastructure, prioritizing the construction and revitalization of academic hospital. On a recent visit to George Mukhari Hospital in Garangua, I witnessed the dire effects of inadequate health infrastructure. Starting with George Mukhari Hospital, we'll be working with various public and private financing institutions to financing the building and revitalization of healthcare facilities, close quotes. Now, Chair, the department wasted no time to bring these pronouncements of the president to life. I must emphasize, however, that we are not starting from ground zero. A lot of strategic health infrastructure is already under construction as I'm speaking here to you. The Limpopo Central Academic Hospital with 488 beds is 43% at completion stage. The Siloam District Hospital in Limpopo, which is a 224-bed replacement facility, is at 92% completion. The Thabeng Regional Hospital in Bethlehem in the Free State is at 57% completion. Bambisani District Hospital in the Eastern Cape at OR Tambo District, 69% completion. Bophelong Psychiatric Hospital in Northwest, 38% completion. Mapulaning Hospital, which is a regional hospital, is at 92% completion. Middleburg Hospital is just waiting for the president to give a date to open it officially. In February this year, during the budget speech, the Minister of Finance announced the increase in the capacity of the budget facility for infrastructure. This is an instrument, honorable members, for managing large public infrastructure projects. Treasury has pronounced 4 bid windows in this financial year for departments to bid for any infrastructure that is more than 1 billion rand. We as health will be submitting 11 bids starting in the July bid window, and we are going to do it as follows. Dr. George Muka Academic Hospital in Gauteng, Victoria Mklenge, which used to be called King Edward VIII Hospital in KwaZulu-Natal, Nelson Mandela Academic Hospital in Eastern Cape, Chilizini Regional Hospital in Limpopo, a replacement of a completely aged facility, as well as Elim Hospital in Limpopo, another replacement of a completely aged facility, and then Soshanguve District Hospital in Gauteng. Then, as well as Diepsloot District Hospital in Gauteng, Taban District Hospital in Dobsonville in Gauteng, El Dorado Park Hospital also in Gauteng, Holomisa Hospital in Holomisa, informal settlement in West Honoria, also in Gauteng, then Mpumalanga Mental Health Hospital in Mpumalanga. Honorable members might be surprised why so many hospitals for Gauteng. This has been studied over many years. Kisani Baraganath Hospital is unable to function as an academic hospital because people are using it as a clinic, district hospital to serve a huge growing population of Soweto. That's why we are putting so many facilities. The other facilities are 6 community health centers, which will be announced in due course. The second announcement that the president made during State of the Nation address, if I quote him, open quotes, in support of our program to prevent and ultimately eliminate HIV, we will be undertaking a massive rollout of lenacapavir, a 6-monthly injection that has proven highly effective in preventing transmission of HIV. I can announce to you today, honorable members, that the president has given us the date of the 5th of June to launch lenacapavir. And Honorable Chair, I've already sent you an invitation for the committee. In the next 2 weeks, we will be delivering lenacapavir stocks to depots and facilities. We will be starting with 306 health facilities in high-burden districts of the country. We have specifically targeted the following categories of population for prioritization. 1, adolescent girls and young women aged 24, pregnant and breastfeeding mothers as number 2. Number 3, female sex workers, and number 4, men having sex with men, transgender people, and injecting drug users. Honorable members, we are in a position where we dare say we can eliminate HIV/AIDS as a public health threat by 2030. All we have to do is to work hard and to work hard together as South Africans, motivated by a common bound and motivated by a common destiny. As a country, we know that what is at stake because we have seen results before. When we increase life expectancy, reduce maternal mortality, reduce under 5 mortality, and reduce TB incidence from 4,717 per 100,000, which moved from a high of 808 per 100,000. We achieved all this by taming the scourge of HIV and AIDS. Imagine, honorable members, what South Africa can achieve if we worked hard together once more to reduce HIV and AIDS. The third and last announcement the president made was about eliminating cervical cancer. That is the cancer of the cervix of the womb. And I quote him again. He said, we are also working to end cervical cancer in our country by mobilizing society to ensure that every young girl between the ages of 9 and 15 years received an HPV vaccine. Honorable Chair, cervical cancer is the second biggest killer of women after breast cancer. Without any doubt, honorable members, cancer is also becoming our new HIV/AIDS pandemic. All the signs are there. The sooner we do something about it, the better. Scientific advances have now put us in a position where it is possible to eliminate cervical cancer. The WHO has delivered a formula called 90-70-90. Many honorable members will remember the formula of 95, 95, 95 for HIV. This is a new formula for cervical cancer. What it means is the 90, that young girls between the ages of 9 and 15 years must receive the HPV vaccine. The second, middle 70, is that women between the ages of 35 and 45 need to be screened with a new DNA-based technologies. Most ladies here in this house will remember the pap smear. We are replacing the pap smear with a more advanced DNA technology. Now, while this formula from World Health Organization is saying 35 and 45 years, because of our unique situation on HIV, we have modified this formula specifically for South Africa. Why? Because in our country, 65% of all women who have been diagnosed with cervical cancer are actually HIV positive. So for that reason, we have added 10 years before the 35 and 10 years after the 45. This means we ought to work harder than all the other countries, honorable members. The last 90, meaning women who are already at stage 3 and 4 need to be treated. And we don't really want to arrive there because it's going to be very complex and very expensive. Honorable members, we have also undertaken to screen 5 million people on an annual basis for TB, and we shall be using modern digital X-ray. I'm happy to announce, honorable members, that on Monday, this very same week, I received 2 digital portable X-ray machines from the ambassador of the Korea Republic. This X-ray equipment can be carried on your bag, so you can climb mountains, you can go anywhere, and it's also attached to artificial intelligence to read the X-ray. Ordinarily, X-rays are read by qualified radiologists, which we don't have in rural areas. Honorable Chair, you are aware that austerity in health has taken a toll on us for more than 10 years. Last year, the Minister of Finance decided to start a move to take us out of this austerity. He allocated 6.7 billion rand for us, and we decided to use it for 4 important functions: to hire 1,200 post-community health doctors, hire 27,000 community health workers, acquire 1.4 million articles worth 3 billion rand to spice us public hospitals like beds, linen, bassinet, mattresses, towels, blankets, etc. And lastly, to pay for accruals for very important, which will accumulate over 10 years. I wish to give an account of how far we have gone in this regard. On the hiring of 1,200 doctors, we received this money in October last year. We have already hired 933, as I'm speaking to you, in the first 3 months of this year only. On the issue of community health doctors, the 27,000, we've already hired 22,856. On acquiring beds and linen and other articles, I can assure you that we've already bought 25,589 beds, 88,333 mattresses, 73,348 linen articles, which were procured by the end of March. On accruals, we've paid 1.4 billion rand. Honorable House Chair, I wish to thank the Acting Director General, Professor Nicholas Crisp, and the team he is leading with the hard work that they are doing to make us arrive here where they are. Honorable House Chairperson and honorable members, I hereby present to the House the budget of National Department of Health, which is 64,807,200,000, 64,807,000,000 rand for the consideration of this House. Thank you, Chairperson, and I'm aware that I'm left with a lot of time, which you must add at the end of my speech. Thank you very much. Yes, I need it at the
thank
end.
you. Thank you, Honorable Minister. Indeed, you have saved time. You will be advised how much time will be added to your speech at the end of the debate. The next speaker is the Honorable Mutambi.
Thank you, House Chairperson, Minister Dr. Motsoaledi, Deputy Minister Dr. Pata, distinguished guests, and my honorable dear colleagues, the Masiari. The African National Congress remains firmly committed to advancing universal health coverage and building a health system that places the dignity of every South African at the center. This budget vote is not merely about numbers on paper. It's about whether a child in a rural village in Muketsi, a pensioner in a township in Inanda, or a young mother in an overcrowded clinic can access quality health care without fear, delay, or financial hardship. 30 years into democracy, we must confront the reality that South Africa still operates within a deeply unequal two-tier system. On the one hand, a well-resourced private sector that serves the minority of the population, while on the other, the public health systems continue to carry the overwhelming burden of care under immense financial operational pressure. The findings of the health market inquiry and the Section 59 investigation expose structural inequalities, exclusionary practices, and rising healthcare costs that continue to undermine equitable access to healthcare. It is for this reason that the implementation of the National Health Insurance remains a historic and necessary intervention. NHI is not just a simply financing mechanism. It is a social justice program aimed at ensuring that access to healthcare is determined by need and not by one's income or geographical location or medical aid status. House Chairperson, as we move towards the national health coverage, we must recognize that health innovation is no longer optional. Innovation has become central to improving service delivery, strengthening healthcare systems, and restoring public confidence in the sector. The future of healthcare lies in digital transformation, integrated systems, and evidence-based innovation. The implementation of interoperable electronic health records, telemedicine platforms, artificial intelligence, pharmaceutical innovation, and point-of-care diagnostic technologies has the potential to significantly reduce waiting times. It has the potential to improve continuity of care, strengthening disease surveillance, and expand access to the underserved communities. In many rural areas, which the majority of us come from, patients continue to travel long distance simply to access specialist consultation or diagnosis services. Through the telemedicine and digital health solution, we can bridge these inequalities and bring healthcare closer to the people. Technology can no longer be viewed as a luxury reserved for urban academic hospitals. It must become an instrument of equity that reaches district hospitals, clinics, and community healthcare centers across the country. However, House Chairperson and honorable colleagues, we must acknowledge the uneven implementation of innovation across provinces, which continue to reinforce inequality. Some provinces are advancing on digital health system, while others still struggle with basic infrastructure, unreliable internet connectivity, and inadequate ICT capacity. This fragmented approach undermines the national health outcomes and requires coordinated leadership, sustainable funding, and stronger intergovernmental collaboration. At the center of health transformation, there are people who sustain this system every day. We therefore pay tribute to all these healthcare workers across the country in the name doctors, nurses, pharmacists, community healthcare workers, emergency personnel, and all frontline staff who continue to serve under extreme difficult conditions. Yet we must broaden our understanding of the healthcare workforce. The future of the healthcare also depends on medical scientists, laboratory professionals, biomedical engineers, digital health specialists, data analysts, researchers, and implementation scientists. South Africa, therefore, requires a new generation of multidisciplinary professionals capable of developing, validating, implementing, and monitoring technologies that respond directly to our local disease burden and healthcare realities. If we are serious about innovation, we must invest in training institutions, postgraduate development, research, infrastructure, and skill retention strategy. We cannot continue to lose skilled professionals to private sector or overseas market because of poor working conditions, limited career progression, and instability within the public sector. Equally, it is important that the equitable distribution of skill between urban and rural communities. Rural healthcare facilities cannot remain sites of chronic vacancies, collapsing infrastructure, and inadequate specialist support. Universal health coverage will remain incomplete if quality of healthcare continues to depend on one's address. The communities do not experience healthcare through policies, documents, or strategic plan. They experience healthcare through long waiting times, medicine shortages, overcrowding, and then broken equipment, delayed ambulances, and the attitudes they encounter when seeking care. So therefore, it is important that public confidence in the health system must also then be restored, and then people will have confidence when they see real improvements in the quality, responsiveness, and dignity of healthcare services. We must therefore strengthen the role of the Office of the Health Standards Compliance to ensure that health facilities comply with the norms and standards, and that patient complaints are addressed effectively and transparently. House Chairperson, this budget vote also comes at the time of growing financial fiscal pressures. Decline health budgets in real terms threaten the sustainability of essential programs, infrastructure development, workforce absorption, digital transformation initiatives, and broader implementation of health reforms. At the time when the population continues to grow and disease burdens are becoming increasingly complex, reduction in healthcare spending will have direct consequences for patient care and health outcomes. We must protect the social wage and prioritize investment that directly improve patient outcome, strengthen preventative health care, expand primary health care services, and modernize public system. Chairperson, this country is in a defining moment in the transformation of the healthcare. Therefore, the ANC support this budget as a commitment to restoring public confidence in the healthcare system by ensuring investment aimed at reducing waiting times in our clinics and hospitals. This budget is an investment in creating a robust system which is responsive to patients' needs and is primarily concerned with improving patient experience and health outcomes. By rejecting this budget, South Africans must be aware that political parties will essentially be rejecting provision for unemployed graduates, as the minister has said, and the other professionals to be absorbed into the system. They will also be rejecting investment to ensure equitable access to essential medicine. They will also be rejecting investment in infrastructure, innovation, and the urgent task addressing the equality of healthcare. As I conclude, Chairperson, I want to remind you of what Nelson Mandela once reminded us, open quote, "A nation should not be judged by how it treats its highest citizens, but its lowest ones," close quote. As such, the trajectory of our nation should be judged by quality of life of the poorest within society, from our villages back home, and not the rich at the affluent areas. As the ANC, we support this budget as a commitment to a South Africa where access to quality healthcare is not a privilege, but a right to be enjoyed by all. I thank you.
Thank you, Honourable Member. The next speaker is the Honourable Muthubatse.
No, thanks, Chairperson, and thanks, colleagues. Honorable Chairperson, the MK Party does not rise today to engage in polite debate over decimal points and line items. We rise to challenge the very soul of a budget that serves the masters of capital while our people perish in the corridors of state-sponsored neglect. This is not a budget, but a death warrant signed in the cold and feeling ink of neoliberal austerity. The Treasury speaks the sanitized language of fiscal constraints. The MK budget calls it what it is, structural violence. You ask the poor to do more with less, whilst per capita expenditure on black working class continues to plummet. We reject the self-congratulatory narrative of a 2 billion nominal increase. In this economic climate, that is not increase, no. It is calculated withdrawal of care. It is a retreat from constitutional mandate to provide health care as a human right. This budget dresses itself as rhetoric of transformation, but it is fundamentally disconnected from the lived reality of our clinics, whilst our mother in the rural village is told there is no Panado, there is no beds, there is no hope. The parasitic elite, the tenderpreneurs, and the bureaucratic fat cats are using the proceeds of the very same budget to choose their second or third offensively blue Lamborghini. This is not merely corruption. It is the theft of life itself. Every cent diverted from the clinic to a luxury dealership, it is a heartbeat stolen from our people. We must address the 2.4 billion burden on the Gauteng health system. Let the record reflect. Our stance on illegal immigration is not rooted in hate, but in revolutionary realism. True Pan-Africanism is about shared struggle, not the liquidation of our national social wage. We cannot build a socialist sanctuary for the continent if our own public health foundation is collapsing under the weight of uncontrolled systemic strain. We demand a health system that acts with fortified fortress of the South African worker. Why does the NHI remain a distant dream trapped in a bureaucratic framework? It is because this government is a hostage of medical industrial complex. You are terrified of the private hospital cartels and the medical aid schemes that treat human body as a vessel center rather than a vessel of dignity. The MK party demands a total decommodification of healthcare. We do not want an NHI that acts as a middleman, buying back services from the very capitalists who exploit us. We demand the nationalization of the private healthcare sector. And therefore, we demand one country, one health system, and that must be clear, on one standard of care. No platinum care for the elite and the plaster care for the poor. Anything less is just medical apartheid rebranded in the 21st century. For over 32 years, this department has acted as a branch of the Western big pharmaceuticals, maintaining colonial blockade against our African heritage. The silence on traditional health practitioners is a betrayal to our ancestors and the denial of our sovereignty. The MK party demands the total decolonization of the health budget as follows. We demand the dedicated multi-billion rand investment on the National Traditional Healing and Knowledge System College. We must stop being a dumping ground for foreign drugs. We demand the state-led manufacture of essential medicines on South African soil. Traditional healers must be integrated into the primary healthcare workforce with a dedicated budget for line, for research, for regulation, for institutionalization. We must break the monopoly of Western medical hegemony. If this government is serious about the health of our nation, we demand the following: the reverse of real-time cuts, the end to outsourcing, and accountability at all levels. Honorable members, the time for careful curated plans and managed failure is over. We do not seek to reform a broken system. We seek to overthrow it in favor of our people. And it is for that reason that our people must vote for the MK party on the 4th of November. We want a budget that reflects redistribution of life. We want a wealth that is of this land that flows into the veins of the worker, into the elderly, and the child in the deep rural heartlands. This budget is a tool of the oppressor, the capitalist, and the status quo. Therefore, as the Vanguard Party will not stop to make sure that we transform the health sector and will say power to the people. Health is a right, it's not a commodity. People must vote for the MK party on the 4th of November.
The next speaker is the Honorable Leroux.
Is this not working? Oh, there we go. Thank you. Honourable House Speaker, it's a well-trodden maxim that budgets reveal what our priorities are. The process leading up to this year's budgetary review for health has unearthed some significant concerns. First of all, although there's a slight increase in the allocation by Treasury to health when compared to last year, health departments all over the country remain under real fiscal strain. For example, the South African government cannot afford to employ even a fraction of the young doctors completing their community service year. Many provinces like the Eastern Cape begin the financial year by spending up to half of their budget just to settle the previous year's accruals, and many institutions are in real trouble, like the NHLS, which is owed more than 11 billion by the provinces, with KwaZulu-Natal and Gauteng the biggest offenders. Secondly, the capacity of the National Department of Health has been considerably denuded by the arrest on charges of corruption and the subsequent suspension of the Director General, the Chief Financial Officer, and a Deputy Director General. Perhaps this is why the department's annual performance plan shows a distinct lack of ambition. For example, the department is only aiming for 81% of people who know they are HIV positive be on life-saving ARVs this year, when our target as a country is 95% by 2030. Similarly, the goals for treatment success in drug-sensitive TB is also a lowly 81%. Thirdly, despite the significant degradation of the health system and widespread corruption from Tembisa Hospital to the oxygen tender to the very top of the National Department of Health, it appears that the department is unable to correctly diagnose the causes of this degradation. The Minister has, for many years, and again through his input throughout the BRRR process, assigned a clear scapegoat, namely the private healthcare sector. It seems to be why the NHI Act, through Section 33, will effectively ban medical aids and private healthcare in South Africa if fully implemented. Internationally, there are only two countries where private healthcare is completely banned, namely Cuba and North Korea, both well known for their oppressive regimes. Minister, as a fellow clinician, I respectfully but fundamentally disagree with your diagnosis. Though inequality in health is indeed a problem, and though our public health care system requires more sustainable financing, this cannot be achieved through the expropriation of monies paid willingly towards medical aids by hardworking middle-class South Africans, the majority of them Black, which they do to ensure they get the high-quality healthcare the government sector has been unable to provide. Minister, when it comes to diagnosing the causes of dysfunction in the public system, I take my cue from the esteemed Professor Salim Abdul Karim, who in a presentation to the Health Portfolio Committee identified the three top causes of dysfunction as, number one, the profound managerial incompetence throughout the public health system, two, the high levels of corruption, largely due to a lack of checks and balances and a lack of accountability, and three, a high health salary bill, yet very poor productivity. Let me make it very clear. South Africa is privileged to have many remarkable healthcare workers who do world-class work. I think we can be incredibly proud of Prof. Bloomberg and the team from the NICD who managed to diagnose the very rare Hunter virus as the cause for the outbreak on that ship in the Atlantic. In fact, the reason why public healthcare sector hasn't collapsed is, in my opinion, due to the many amazing clinicians who keep on fighting on despite the many challenges. But, honourable members, they are getting disillusioned and many are leaving the public sector every year. Unfortunately, the department's annual performance targets focus on superficial employment and equity targets rather than addressing the competence, capacity and accountability of its employees. Appointing the right people with the required scarce skills is crucial in the healthcare sector, and this should be done on merit alone. We must also remember that the public healthcare sector is serving the public and not the doctors, nurses, and administrators who work there. And we must remember that it is not there for the tenderpreneurs who want to make a quick buck, but for the public of South Africa, many of whom are elderly, vulnerable, poor, and of course ill. They do not deserve to have their dignity trampled on each time they visit a hospital or clinic. They do not deserve to wait in endless queues, be told that their medicines are out of stock again, be shouted at or misdiagnosed or left to lie in wards in their own urine, while those who are meant to care for them watch videos on their telephones. This year's B-R process indicates to me that the department has run out of ideas about how to run the public healthcare system. The last genuine attempt to finding a solution was the drafting of the NHI legislation, which we are all aware is in front of the Constitutional Court at the moment. But instead of a broad consultative process that tries to harness the strengths of the public and the private healthcare systems in ways that provide practical solutions, the legislation seems to have been hijacked by the ideologues within the ANC who, like the Minister, blame public sector failures on the private sector. Minister, instead of questioning the impartiality and fairness of the judges on the Constitutional Court, why don't you remove Section 33 of the NHI Act, reform the private healthcare sector in line with the Health Market Inquiry recommendations, and start working on a financially and practically viable NHI with us so that we can unlock and truly transform the South African healthcare sector? I thank you.
Thank you, Honourable Member. The next speaker is the Honourable Chirwa Pungoshe.
Greetings to the Commander-in-Chief of the EFF, Julius Sello Malema, the leadership and ground forces of the Emancipation Movement. The Department of Health is characterized by consistent failure, a curative approach to healthcare instead of preventative, executive and management failure, and catastrophic corruption levels. These are the adjustments that we propose as the EFF to save this department from further decay under the stewardship of Minister Motsoaledi. In the midst of collapsing clinics, medicine shortages, staff shortages, HIV and TB pressures, and corruption facilitated by national management and officials of this department, program number 4 for primary healthcare only increases from 3.7 billion to 3.8 billion rands. This is politically indefensible, Minister. How do you plan to deliver a community-centered and prevention-led public healthcare system under this condition? You must increase this allocation by at least 5 billion rands. This is the only way you can prioritize 24-hour clinics in townships and rural areas, mobile clinics, maternal health care, and mental health services. We propose an increase for infrastructure with caution, as we have seen what ANC comrades and allies do with money is meant to build our hospitals and to keep our people alive. Mapulaneng Hospital in Mpumalanga, we were promised a state-of-the-art hospital over 6 years ago. 3 billion rands has been spent to date, and yet there's still no hospital in Namhlanje. And furthermore, at the previous hospital, doctors have to leave operation rooms during surgeries to go and collect water outside because the water tankers are not connected to the hospital. We've raised this with the minister's office, we've raised this with the provincial government, and Namhlanje, nothing has been done. Add 8 billion rands to infrastructure emergency fund to deal with revitalization of rural hospitals, township trauma centers, oxygen and energy backup systems, water infrastructure, oncology equipment, and public pharmaceutical manufacturing infrastructure. The department spends excessively on outsourced services. You must place focus on building internal capacity, and you must cut contractor spending. You must adjust the consultant expenditure by reducing the 250 million allocation by 50%. The 609 million rents for contractors must be reduced by 80%, and the 110 million on travel subsistence must be cut out completely, as there's no reason at all to outsource non-essential services. These are responsibilities the department can already do for itself. You must redirect the approximately 800 million from these cuts towards hiring nurses and doctors, ambulance personnel, biomedical engineers, cleaners, pharmacists, and hospital maintenance teams. The OHSC is heavily underfunded and as such can only inspect 20% of public facilities and only 16% in the private sector. This means that corruption, negligence, and patient abuse thrive. You must increase the OHSC allocation by 500 million so they can employ inspectors on a permanent basis and establish a system that can be monitored nationally for their inspections. This will greatly assist the department itself in the investigations of medical legal corruption. We must add 3 billion rands to emergency medical services nationally. We have a crisis of ambulances, Minister. In provinces like Eastern Cape, Limpopo, Northwest, Mpumalanga, KZN, rural districts, this crisis is actually severe. Furthermore, this crisis exacerbates apartheid special planning that alienates poor communities from vital health services. With this 3 billion, you must expand ambulance fleet, invest in helicopter emergency services in remote provinces, train paramedics, and build a digital dispatch system that actually works. It sounds undoable because for so many years, this department has allowed price inflation and tender procurement systems to thrive. It is actually very much doable. You acknowledge underspending yourselves on human resource. Why not address this? Increase the post to be filled immediately by the following margins. Add 10,000 nurses, 3,000 doctors, 2,500 community healthcare workers, mental health practitioners, and laboratory specialists. Where must the money come from? You might ask. It must come from the money found in wasteful expenditure, wealth taxing financing mechanisms, and anti-corruption recovery. Minister Motsoaledi, we have run out of the patience to tolerate the blatant disregard of this department by the officials entrusted with responsibility. And we blame you because you're the political head. You can no longer claim ignorance when the department you are leading is being looted at this large scale. Not doing anything about it not only makes you complicit, it actually makes you responsible for it. There are hundreds of other issues that suffice that we have raised consistently with you over the years. An example is failure to provide justice for victims of forced sterilization of Black women. You have the recommendations from the CGE, but you're doing nothing about it. Another example is the HIV billion 15 rand tender. 15 billion rand tender. We've highlighted red flags consistently with the minister for over a month, and he has done nothing about it. It will again take the EFF to take the steps to fix the problem in the department that you are leading. Minister, if the heart for this work of keeping our nation alive and keeping humanity alive has left you, please kindly follow your heart. We reject this budget, this austerity budget. In fact, we call on South Africans who wanted 24-hour clinics open 7 days a week to register to vote for the EFF. The GNU leaders access healthcare as and when they please, but they deny this basic human right to the poor and vulnerable South Africans. Vote EFF on the 4th of November for 24/7 clinics in South Africa. Mandla.
Thank you, honorable members. The next speaker, order. The next speaker is the Honorable Mhlongo from the IFP, who's on the virtual platform.
Honorable Chairperson, as a point of departure and given this opportunity, it is important to reiterate the IFP's position in relation to the National Health Insurance. In principle, the IFP supports universal healthcare and access to quality healthcare for all South Africans is an ideal we must continually aspire to. However, central to the IFP's reservation is the absence of a clear and credible funding model in its current form. Honorable Chairperson, a critical component of the department's ability to execute its mandate effectively is the strengthening of its healthcare workforce. It is therefore deeply concerning that despite widespread shortages within the public healthcare system, many qualified doctors, nurses, pharmacists remain unemployed and have been compelled to protest in frustration. In a developing country such as South Africa, this situation is regrettable, particularly given the numerous complaints from citizens about inadequate access to healthcare services and declining standard of care. Furthermore, our healthcare workers continue to operate under immense pressure, frequently working long hours in difficult conditions. It is therefore imperative that the government prioritize the absorption of unemployed healthcare graduates into the public healthcare system, both to strengthen services delivery and to alleviate the burden placed on existing personnel. The IFP welcomes the department's increased budget allocation of 1.5%. However, we remain concerned that this increase is effectively overshadowed by inflationary pressures and the growing demands placed on healthcare system. Honorable Chairperson, given South Africa's ongoing challenges relating to HIV, AIDS, and tuberculosis, one must commend the department for consistently affording these matters the priority and attention they deserve. The IFP welcomes the various interventions, programs, and scientific research initiatives aimed at combating these diseases and finding sustainable solutions to reduce their impact on our communities. Furthermore, the IFP welcomes the department's intervention to address the funding shortfall caused by the United States government's withdrawal of donor funding from the South African Medical Research Council. The intervention is critical in ensuring the continuation of vital research programs and healthcare initiatives that play an important role in combating diseases and strengthening public health outcomes in South Africa. An important component of providing quality medical care is the availability of adequate and functional healthcare infrastructure. While the IFP notes and welcomes the department's intervention to improve healthcare infrastructure, these efforts remain insufficient given the deteriorating state of many hospitals and healthcare facilities across the country. In light of the matters raised, the IFP supports this budget vote. I thank you.
Thank you, Honourable Member. The next speaker is the Honourable Peters.
Thank you, Honourable House Chair and Honourable Members. Health Budget Vote 18 must be measured not only by the figures we debate in this House, but by the lived realities of our people across urban townships, rural villages, and informal settlements. For millions of South Africans, the right to healthcare remains fragile. Communities continue to face persistent and deepening challenges that undermine access to quality, dignified, and timely health services. We must strengthen primary health care. Clinics and community health centers are the first line of defense for millions of South Africans, yet they remain under-resourced and overstretched. Community monitoring data of over 400 clinics nationally shows that only 55% of clinics had working generators and nearly 30% had no generators at all. The health infrastructure crisis must be faced head-on. Too many hospitals suffer from poor maintenance, equipment shortages, and staff burnout. Investment in modern facilities, reliable equipment, and adequate staffing is essential to restore public trust in the health system. Public health challenges as HIV, TB, maternal and mental health require sustained attention. Vote 18 must prioritize prevention, treatment, and awareness campaigns to reduce the burden of disease and promote healthier communities. South Africa must embrace digital health innovations. Technology can reduce waiting times, improve patient records, and expand telemedicine services, especially in rural areas. Vote 18 must drive this transformation to make healthcare more efficient and accessible to our communities. Honourable Chair, Vote 18 is not just about budgets, it is about lives. It is about ensuring that South Africans is denied care, that no South African is denied care because of poverty, geography, or systemic failure. Let us commit to a health system that is inclusive, modern, and resilient for the dignity of our people and the strength of our nation. A nation that heals its people, secures its future. The Patriotic Alliance supports this vote.
The next speaker is the Honourable Van Staden.
Geachte huisvoorsitter, met 'n begroting van 64 miljard het hierdie departement maar nog steeds na al die jare geweldige uitdagings wat maar net nie oorkom kan word nie. The Financial and Fiscal Commission has highlighted to the Portfolio Committee that a persistent pattern of underspending over consecutive financial years remains a serious concern. At the same time, the department continues to be burdened by exceptionally high legal costs. These are funds that could be far better utilized elsewhere. I've raised this repeatedly over the past few years, and these resources should be directed toward the appointment of doctors, nurses, and both clinical and non-clinical staff, the procurement of essential medical equipment and hospital beds. And I'm glad to hear that you said you have procured a lot of beds and medical equipment, Honourable Minister, and addressing critical gaps in the HIV/AIDS program, particularly following the withdrawal of the PEPFAR funding. Moreover, these funds could be directed toward accelerating the filling of critical vacancies, reinforcing the severely constrained budget of the Office of the Health Ombudsman, and expanding the number of inspectors within the Office of the Health Standards Compliance to ensure effective oversight and strengthen accountability. In response to my written question, the Minister confirmed that the 15 national health insurance court cases alone have cost the department between 2.5 and 3 million rand per case. These expenses have been paid to 6 senior counsel, 10 junior counsel, and their instruction attorneys. The Minister further indicated to me that 74 million has been set aside for these legal costs in this 26-27 financial year. At the same time, medical legal claims against the Department of Health has reached a plus-minus alarming amount of 120 billion rand, with a bulk of these claims arising from the Eastern Cape, Gauteng, and KwaZulu-Natal. Parliament must urgently confront the excessive legal expenditure associated with the National Health Insurance court cases. Immediate targeted interventions are required to curb the rising tide of medical legal claims, as long as service delivery in our hospitals and clinics remain below standard. These claims will continue to escalate, placing an ever-growing burden on the department. It is unacceptable that patients are sent home despite requiring urgent medical procedures simply because critical infrastructure such as the theatre air conditioning system is not functional. And this failure severe undermines service delivery and places patients' lives at significant risk. The Minister must act decisively to resolve these issues, Honourable Minister, beginning with the urgent intervention on this problem currently at the Steve Biko Academic Hospital. Die probleme rondom provinsiale departemente wat nie al uitstaande rekeninge aan die nasionale gesondheidslaboratoriums betaal nie, plaas 'n geweldige beperking op hierdie entiteit om sy werksaamhede sorgvuldig uit te voer. Ons kan dood eenvoudig nie langer so aangaan nie en die minister sal hierby moet ingryp op 'n dringende basis. SAPRA verwyder tans medikasie vanaf apteke se rakke wat vir meer as 20 jaar lank aan die publiek verkoop word sonder enige ernstige voorvalle wat aangemeld is. Medisyne wat langer as 20 jaar op die rak is, word nie bevraagteken nie, maar hierdie tipe van optredes moet met alle erns ondersoek word en die redes daaragter moet ook bevraagteken word. Dit maak nie sin om oornag die verspreiding van medikasie te staak sonder dat enige wetenskaplike wysheid deur SAPRA gelewer kan word wat hierdie optredes van hulle regverdig nie. Ons versoek die minister om behoorlik ondersoek oor hierdie aangeleentheid te doen. The Freedom from Plus supports the recommendations of a portfolio committee. I thank you, as Chairperson.
Thank you, Honourable Member. The next speaker is the Honourable Etlape.
Thank you, House Chair, to the Minister, the Deputy Minister, and the Chair of the Committee. I was listening to the Minister and I was a bit afraid. The last time we had a ministry that was taking orders from the President, we had a disaster. I hope the President supports what comes from the ministry rather than the ministry listening to what the President is saying. You know, there was a word that was used where people talk about maintenance. And when you come into most African languages, we don't have a single word for maintenance. And that is what was missing for me from what the minister was saying. If we cannot maintain our current structures, it doesn't matter whether you give us new ones. They will dilapidate as rapidly as the ones that we have custody of right now. We've been to a hospital that has been built during the new democracy. It was built on a swamp. It's damp. It's not working. We had a fire a few years ago at the Charlotte Maxeke Johannesburg Academic Hospital. Today, repairs are not complete. The minister talks about cancer service. Cancer patients in that hospital have no privacy. The doctors are doubling up in what was a garage. The hospital has not been maintained because somebody is going to come and say, we condemn this hospital and we need to build a new hospital. As long as we don't have a robust maintenance program, all we do will not work. We went on an oversight to Limpopo. The hospital is decaying. When you speak to management, they say there's a new hospital coming up. So, Minister, unless we get resources for maintenance and unless we can maintain what we have, there's really no point in building new hospitals that will never be delivered on time or on budget. So it becomes a way of eating. One of the things that I hope you'd be able to do, Minister, is to act against price gouging. The previous government, which was not democratic, when it bought for the population, it paid the lowest price because of its buying power. The current government, when it buys for the nation, it pays a multiple of what you'd pay in the private sector. So whether the hospitals are new or they are old, if we can't care what happened in Tembisa, we're going nowhere quickly. Price gouging is what is killing our system. And that does not require a National Health Insurance Act to fix. But if we can't fix it, when you pull the money together into a central pot, you are making corruption much easier. You are facilitating price gouging. I come from Gauteng, where they centralized payment under GSSC, and you've never seen as much corruption as you can witness in the Gauteng Department of Health. Lastly, I had the minister talk about technology, X-rays interpreted by AI. I ask, who then takes the responsibility when there are challenges? Is the ministry taking over the responsibility for the harms that may arise from AI, which is not a registered healthcare professional, which is not accountable to anyone?
Thank you, Honourable Member. The next speaker is the Honourable Deputy Minister of Health.
Thank you very much, Honourable Chair. Let me greet yourself, Chair of this session, my colleague, the Minister of Health, Dr. Motsoaledi, our Chairperson of the Portfolio Committee, Honourable Faith Mutambi, and the members of the committee, the honourable members of this House, distinguished guests, ladies and gentlemen. It's an honour indeed to participate in the budget vote 18 for 25-26 in this very important year as we commemorate 50 years of the Young Lions, the youth of 1976, and 70 years of the women Mpokoto, 70 years of the Women's March into the Union Building, and also 30 years of our Constitution. Honourable members, we are again reminded that we're only 4 years to the realization of our targets, not just in South Africa under the NDP, but also strategic development goals as set up by the UN to be achieved by 2030. It is in this regard that on the 25th of September 2025, heads of state gathered in New York at the UN high-level meeting to commit to accelerating action against non-communicable diseases towards 2030. This was followed by a political declaration which was adopted on the 15th of December last year, which was committing countries to making sure that we can eradicate the danger of non-communicable diseases such as cancer, diabetes, heart disease, mental health. Here in our own country, as we push for elimination of infectious diseases with major focus on HIV and AIDS, TB, malaria, and various children's infections, we continue to see a rapid rise in non-communicable diseases, which are listed under the UN General Assembly, plus also chronic lung diseases. We launched our own national strategic plan for prevention of NCDs in the 6th administration, and I want to thank all the provinces, MECs, and their staff for embracing the plan and rolling out the plan to prevent NCDs in all provinces. Quite recently, I was in the Limpopo province in Guyana, where community members came out in numbers to embrace the prevention and management of non-communicable diseases. Our campaign entails providing health education, focusing on prevention, screening for early detection, and initiation on treatment when necessary. Our integrated approach means that every time when there is a major event, such as World TB Day, World AIDS Day, we provide comprehensive services to promote healthy living and do screening for both communicable and non-communicable diseases. We have also increased our use of media platforms, such as radio, including community radio stations, social media, and also billboards. We extended our screening coverage by training Honorable Mutubats, by also training traditional healers to take blood pressure and also do urine sugar testing. And I must say that I was very pleased a few months ago when I was in your province in the Northwest at the Muruleng with the Honorable Khoshipilani there, where the traditional healers were proud in showcasing how to take blood pressure and also how to monitor urine sugar. And they were very proud to show that they can read the numbers. So we're working with them, and they are making sure that when they pick up those problems, they refer those patients to our clinics. Now, we've managed to conduct, as a result of all these interventions, over the 25-26 financial year, more than 39 million screenings and referrals for blood sugar and also blood pressure. Honorable members, cancer is a major threat, as already mentioned by the Minister, to the progress we are making in helping South Africans live longer and healthier. Leading cancers such as breast cancer and cervical cancer amongst women, prostate and colon and lung cancer amongst men are rising rapidly. The mainstay of managing this, as with other non-communicable disease, is firstly prevention through healthy diets, no smoking, and also minimum intake of alcohol and also physical exercise. Unfortunately, it's only cancer of the cervix which can be prevented also through a vaccine. The rest, we have to go the other conventional way of prevention. Secondary intervention is in terms of early detection, as in the case of cervical cancer. Other cancers can also be detected early through various screenings. If all of those fail, we make sure that we can have facilities to provide treatment by increasing oncology services, supporting provinces to increase their oncology services through our conditional grant. We support provinces through upgrading and maintenance of radiotherapy infrastructure, expansion of diagnostic imaging and pathology services, recruiting and retention of oncology specialists, especially in rural provinces. We take note of what Honorable Letape said about the situation in Charlotte Maclegan. We have been supporting Gauteng as well, specifically Charlotte Maclegan, to make sure that it can function optimally. But we take note and we will be making follow-up in that regard. Mental health is also an area of pressure of our health systems. Over and above other social conditions which trigger mental health, the explosion of substance abuse amongst our young people is putting our facilities at a very serious pressure, right from district right up to central hospital level, where our casualty departments are clogged with many young people, especially young men, who consume lethal substances. This is not just a health challenge, but it's a challenge for all of us, whether in our political organizations, social organizations, traditional and also religious. It's an all of society problem which we must all handle together. In order to increase access to mental health services, we have integrated mental health into our primary health services, with 75% of community health centers having at least one mental health care provider that is either, even if it's not full-time, but visit by a psychiatrist, a doctor, a psychiatric nurse, psychologist, or a registered counselor. As we expand all these services in the midst of a high burden of disease, we have to keep on innovating. And one of those innovations is the Central Chronic Medicine Dispensing Program. This program, wherein patients who are stable on treatment for NCDs or chronic infectious conditions such as HIV, can receive their medication nearer to their homes at pharmacies, GPs, Community centers, halls, and even traditional authority offices have been growing. We currently have 2 service providers who receive scripts from over 3,000 facilities and deliver at pickup points. As by the end of March this year, just over 3.6 million patients were participating in this program. Patients can now receive up to 3 months of packages of treatment or their prescribed treatment so that they can reduce traveling and other costs. Over 2 million of beneficiaries are on antiretrovirals and the others are for other chronic ailments. Honorable members, no nation can improve its health without looking after its young people. And it is in this regard that, working together with the Department of Basic Education, we have been also ramping up our integrated school health program. As we speak, this program, which has been running since 2012, over the last 16 years, more than 10 million children have benefited. Outside school services, we also provide youth-friendly services at our primary health service centers. We have youth zones, which make it possible that young people can come and receive care and advice, advised by younger staff, members of staff, also protecting them from sometimes interference by us as the parents. So in these youth zones, they are able to receive those services without the fear of interference by us, the parents. As we speak about young people, honorable members, we also take note of the fact that the issue of one of the major challenges amongst our youth is the issue of this new novel cigarettes called e-cigarettes and vaping, which are very dangerous, where there is ample proof that indeed they have severe impact on respiratory systems, and also cardiovascular systems. We implore the Honorable Committee to speed up the approval of the bill, which will make sure that we can be able to control and regulate these areas. Chairperson and honorable members, I also implore on all the members of this House to support Vote 18 for the National Department of Health. We move forward with the implementation of NHI. Thank you.
Thank you, Honorable Deputy Minister. We now invite the speaker from ACDP. Do we have an honorable member from ACDP? Order, honorable members. We now invite the Honorable Nontenja, who will be on the virtual platform.
Thank you, Honorable House Chair. On behalf of the United Democratic Movement, I rise in support of Budget Vote 18 with the hope that it will assist in changing the hardship endured by those in informal settlements and rural areas. Millions of South Africans continue to walk into overcrowded clinics, collapsing hospitals, medicine shortages, and painfully long waiting queues. While government presents polished reports and ambitious plans, ordinary citizens are experiencing a healthcare system that is struggling to provide even the most basic standard of dignity and care. The crisis in public health is no longer an isolated concern. It has become a daily reality for millions of South Africans who depend entirely on the state for survival. Serious inequality also exists between private and public health sectors. While a small percentage of citizens can afford quality private care, the majority depend on public facilities that are under pressure. This unequal system deepens poverty and frustration among ordinary South Africans. How budget is allocated becomes imperative. Honorable House Chair, the challenges facing our health sector are not only about infrastructure or funding. They are also about governance and accountability. Corruption in procurement, poor financial management, and delays in infrastructure projects continue to weaken service delivery. The UTM believes that quality health care is not a privilege. It is a constitutional right that every South African deserves. However, rights mean very little when hospitals are understaffed, infrastructure is collapsing, and corruption continues to drain resources meant for the people. I thank you.
Thank you, Honorable Member. The next speaker will be the Honorable Ghana on the virtual platform.
Minister, the Department of Health, as we know, has been allocated just over 66 billion for this financial year. But when one walks through the overcrowded corridors of our public hospitals, when one sees patients sleeping on benches waiting for treatment, when one listens to mothers who wake up at 4 o'clock in the morning to stand in queues at clinics, we know that this budget is simply not enough for the growing demand for healthcare services in our country. Yet today, we must not only speak about the size of the budget, we must speak about how wisely and honestly this money is spent. Because every rand wasted through corruption is a rand stolen from a sick child, from a pensioner waiting for medication, and from a family praying for quality healthcare. For us as Rise Mzansi, the priority remains clear: access to high quality healthcare for every South African, and it is non-negotiable. There are 5 things, however, that we would like to see the budget address. Firstly, we must accelerate the fight against HIV/AIDS. In the coming month, South Africa will begin the rollout of lenacapavir, a groundbreaking HIV prevention treatment. This presents us with a historic opportunity to drastically reduce new HIV infections. But this medication must reach those who are most vulnerable and most at risk. We cannot fail young women, vulnerable communities, and those who continue to carry the greatest burden of this epidemic. Secondly, we must clean out procurement and supply chain corruption in the Department of Health in provinces. The looting of Tembisa Hospital of nearly 2 billion rands through the abuse of the quotation system without even a measured tender process is actually criminal. Lifestyle audits for every official responsible for procurement must become the new normal. Public healthcare cannot become a feeding trough for corruption. The third thing that we want to see this budget focusing on is the maintenance of hospitals and clinics, which must happen urgently. No patient must receive a healthcare in a collapsing building, a leaking ward, broken toilets, or facilities without water and electricity. Dignity matters in healthcare. The fourth thing that we would like the budget to address is the need to ensure that there are healthcare professionals in every healthcare facility. The doctors, nurses, pharmacists, and specialists are a critical part towards quality public healthcare. Lastly, we need a proper service level agreement with our neighboring SADC countries on healthcare provision so that our healthcare system remains sustainable whilst protecting human dignity. In Chamastul, we have the opportunity to make this budget travel further and reach more people who depend on public healthcare. We cannot afford a collapsing public healthcare system because when healthcare collapses, people do die.
Thank you, Honorable Ghana. The next speaker will be the Honorable Dr. Mayemane on the virtual platform.
Thank you very much, Chairperson, and good afternoon to fellow South Africans. Honorable members, I think this debate on the budget of the healthcare needs to uphold our constitutional obligation, which is the provision of universal healthcare. If that is the unifying point of consensus, well, I want to urge that we need to find a solution that is not built in the courts, because certainly courts cannot be the first place that dictate what public policy must be. We must certainly come around the table and find workable solution about how to fund our healthcare crisis. The reality of the matter is that 80% of our citizens are dependent on public healthcare. Yet, only between 15 to 16% access private healthcare. And in truth, this conversation is not just unique to South Africa, it is a global conversation. Minister Motsoaledi, I recall quite recently I had to attend to a medical emergency that was personal to me. I went into the hospital. it became quite clear that instead of just being a patient, I became a cost center. Every item was inflated, and eventually my medical bill became excessive, that indeed it became true that for citizens they could not afford it. I was grateful in the fact that at some simple level I'm subsidized, but at a truer human level and a human rights level, I must think hard about how do we provide healthcare for all citizens in the country. The second issue is the fact of the federalization of healthcare. When we give all the MECs the right to determine what their healthcare outcomes need to be, there are some challenges. I attended to some provinces where it became quite clear that their healthcare budget for this year was being used to subsidize incidents that took place last year, which diminishes the quality of healthcare for citizens in those provinces. Thirdly, I really do believe, honorable members, we need to attend to the question of corruption. I don't need to lament what all honorable members have said, but it is clear that what took place in Visa undermines the argument that we seek to achieve of providing healthcare for all citizens. It is clear what is taking place in Pretoria Hospital in the Eastern Cape is a genuine challenge. Lastly, honorable
open ticket for SAA. I had an open ticket.
Sorry, Speaker.
I just made a book.
Apologies,
may I ask
Honorable
that
Musi.
my
You are
time be
protected.
adjusted accordingly? Thank you.
We are doing just that. Honorable Maimane, continue.
I appreciate that. The third point I want to make is it's common cause that our healthcare budget has been dealt a blow by the withdrawal of PEPFAR. Now, in this particular reality, it is clear that this budget will not be sufficient to mitigate against the effect of that. I welcome the intervention that the minister announces on health, on HIV intervention and a 6-month vaccine program, or rather HIV prevention program. What we need to do is do more to find the funding to balance off what has been lost through HIV, through PEPFAR funding, to ensure that we build better infrastructure and employ more doctors in order to reduce the ratio between doctors and patients. And so, honorable members, we support this budget conditioned on the fact that we need to fight hard to settle the debate on how we provide universal healthcare coverage, budget better, so that we can provide universal healthcare coverage for all of our citizens. Thank you very much.
Thank you, Honorable Maimane. The next speaker will be Honorable Member from ATM. Honorable Member from ATM. The next speaker will be Honorable Member from Al Jama. Honorable Member from Al Jama. On the virtual platform. The next speaker will be the Honorable Member from NCC.
Thank you, Honorable Chairperson.
Yes, continue, Honorable Ismail.
Thank you so much, Chairperson, fellow beloved family of South Africans. Al-Jamaa notes, vote 18 on health. Healthcare is a fundamental human right, yet millions of South Africans continue to face long queues, shortages of medicine, understaffed hospitals, and deteriorating healthcare infrastructure. Rural and vulnerable communities remain the hardest affected. We call for urgent strengthening of public healthcare facilities, improved working conditions for healthcare workers, greater investment in mental health services, and decisive action against corruption and mismanagement within the health sector. Al-Jamaa further emphasizes the importance of preventative healthcare, community awareness programs, and ensuring equal access to quality healthcare services for all South Africans, regardless of their social or economic status. A healthy nation is a productive nation, and government must prioritize the dignity, well-being, and lives of our people above all else. I thank you. Malibongwe.
Thank you, Honorable Member. The next speaker will be Honorable Member from NCC. Honorable Member from PAC. Honorable Member from UAT. Honorable Member from Good. The next speaker will be the Honorable Clerk.
Thank you, Chairperson. Good afternoon, members. Today we confront a painful truth. South Africa's public health system is in crisis. This crisis is no longer hidden in reports or committee briefings. It's lived every day by millions of South Africans. It is the mother waiting hours in an overcrowded clinic with a sick child. It is the patient turned away because there is no medicine. It is the ambulance that never arrives. It is the exhausted nurses working double shifts while corruption flourishes above them. This is not only a healthcare crisis, it is a crisis of governance, accountability, and political leadership. The committee has identified a deeply troubling pattern within the Department of Health. Plans without implementation, budgets without outcomes, and promises without accountability. Year after year, expenditure increases, yet hospitals remain overcrowded, clinics remain understaffed, infrastructure continues to collapse, and public confidence continues to decline. At the center of this collapse is corruption. We must stop treating corruption as a side issue. Corruption is one of the primary causes of healthcare crises. Every irregular tender means fewer nurses, ambulances, fewer medicines, and fewer lives saved. The committee has identified serious concerns relating to procurement irregularities, weak financial controls, abuse of public funds, and failures in consequence management. South Africans are tired of hearing that investigations are ongoing, and they are tired of endless suspensions at full pay. They are tired of politically connected individuals escaping accountability while hospitals crumble around them. Corruption in the healthcare is not a victimless crime. It is theft from the sick, it is theft from the poor, and ultimately it costs lives. These responsible for looting public healthcare must face swift disciplinary and criminal consequences. Anything less is complicity. Equally alarming is the catastrophic shortages of healthcare workers. How is it possible that hospitals are overwhelmed and clinics are understaffed while qualified doctors, nurses, pharmacists, and healthcare professionals remain unemployed? Healthcare workers are the backbone of the system, yet many are overworked, burnt out, and forced to operate in intolerable conditions. Nurses are caring for impossible numbers of patients. Junior doctors work brutal hours without adequate support. Emergency services operate without sufficient personnel, vehicles, or equipment. You cannot optimize a collapsing system. South Africa does not need austerity disguises as reforms. We need urgent recruitment, retention strategies, and investment in healthcare workers. No healthcare system can function without the people who carry it every day. The crisis extends beyond staffing. The state healthcare infrastructure in this country is a national disgrace. Hospitals with leaking roofs, broken lifts, unsafe wards, clinics without water, non-functioning theatres, and despite billions allocated in infrastructure projects are delayed, abandoned, or consumed by corruption. South Africans are asking a simple question: where is the money going? Because it certainly is not visible in the conditions patients experience. One of the gravest concerns raised by the committee is the widening gap between expenditure and outcome. The department continues spending more money, yet services delivery continues getting worse. Medicine shortages persist, waiting times remain unacceptable, emergency services continue failing communities during the most vulnerable moments. Unless corruption and mismanagement are confronted directly, no amount of additional funding will fix the system. Universal healthcare is a noble goal, and every South African deserves access to quality healthcare regardless of income. But let us be honest, you cannot build an NHI on the ruins of collapse of the public healthcare system. And Madam Chair, the health market inquiry did not support the NHI. If government cannot prevent corruption in provincial health departments, how will it safeguard a massive centralized NHI fund tomorrow? Before creating a new healthcare system, government must first prove it can manage the one it already has, fix the hospitals, fill the vacancies, stop the corruption, strengthen financial controls, and restore public confidence. What emerges from this report is not a series of isolated failures, but a pattern: weak accountability, systemic corruption, critical staff shortages, failing infrastructure, and a widening disconnect between what government reports and what ordinary South Africans experience on a daily basis. The committee has made clear recommendations: strengthen financial oversight, consequence management, fill vacancies, and improve infrastructure accountability. But ultimately, this comes down to political will. Do we have the courage to confront corruption within the health system? Do we have the courage to prioritize patients over political connected individuals? South Africans are asking for dignity: a clinic that functions, an ambulance that arrives, a hospital with medicine, a healthcare system that treats people like human beings. And Chair, no wonder our country has a health crisis.
Honorable Clerk,
even our minister
unfortunately, your time
second-guesses
has
the
expired.
judiciary publicly. It is shocking, to say the least.
Thank you, Honorable Member. The next speaker will be the Honorable Sinne.
House Chairperson, Honorable Minister, Deputy Minister, Portfolio Committee Chairperson, Honorable Members, fellow South Africans. The transformation of our health system is an inseparable pillar of the constitutional project that defines our democracy. Our constitution is the living breath of the Freedom Charter, asserting daily that South Africa belongs to all who live in it, transcending the barriers of race, class, and gender. It is noteworthy that the Freedom Charter refers to legitimate citizens of our land when it affirms all those who live in our land. It does not clamor for an ill-defined and nebulous concept of all who live in it. Instead, it places our nationhood in a nexus with Pan-Africanism. This continuity of the Freedom Charter is most visible in our global leadership of the world's largest antiretroviral therapy program. When the skeptics and cynics predicted that the withdrawal of PEPFAR funding would be our undoing, they underestimated the resolve and indomitable spirit of the ANC and the presence of resilience, policy content, and trajectory. House Chair, we did not blink, we did not flounder, and we did not flow. We allocated 754 million to bridge the gap, including a 410 million investment in the South African Medical Research Council. This is more than a line item. It is a declaration of total confidence in our own scientists and our own sovereignty. House Chairperson, we are on the verge of the 95 UN/AIDS finish line. Currently, 96% of people living with HIV and AIDS, HIV know their status. However, while 94% of those on treatment are virally suppressed, only 78% of those diagnosed are on ART. This 17% gap is where our work lies. We will intensify this campaign to prolong lives and ensure that the quality of those lives is equally enhanced. The final push towards 2030 demands innovation that reflects the lived reality of our people. The arrival of the first 38,000 doses of lenacapavir is a revolution. It liberates our adolescent girls and young women from pill fatigue and the shadow of stigma. By integrating this into our Close the Gap campaign, we are not just treating a virus, but restoring dignity and laying a firm foundation for our onset of universal health coverage overall. House Chairperson, healthcare does not begin at the clinic door. It begins in the environment, the water, and the soil. We demand a whole of society approach to confront poverty and sanitation with the same urgency as a clinical emergency. We also ensure that every patient must be tracked, supported, and retained in a care through robust communication mechanism. We also need to defend our youth by passing the Tobacco Bill Products and Electronic Delivery System Control Bill. Our youth are under siege by nicotine addiction, and we will not trade their health for industry profits. The youth are our future. We dare not linger. Honorable House Chair, this budget prioritizes primary health care, directing over 44% of resources to district health services. This is the front line. Modulasetulo, ntumelele ke lebogishe the Northwest Provincial Department of Health for exemplary absorbing of 62 bursary holder doctors, achieving a 94% appointment rate in district health services is a landmark victory, ensuring medical officers are in rural clinics, not only in urban centers. House Chairperson, however, many hills remain. We must expand mental health access and transform our clinics into youth zones, fortresses of mandatory reporting against statutory rape, not chambers of silence. Honorable House Chair, as we strive to summit these hills, we do not convince ourselves that the road ahead is easy. Neither do we think that our end goal is a mere mirage. It is within reach. In conclusion, House Chairperson, the ANC supports this budget vote 18. It is an investment in the dignity of the marginalized and a mandate for state capacity to pursue development and enhance the well-being and equality of life of every South African. We move forward within the principle that in South Africa we are building. No one is left behind. No South African will be treated or regarded like a cog in the machine. Everyone's dignity is inviolable. Thank you, House Chairperson.
Thank you, Honorable Member. We now invite the Minister to respond to the debate. Honorable Dr. Mtwaledi.
Yes, thank you very much, honorable members. Honorable Clerk, mentioning well-established facts in public is not an insult to anybody. It's not an insult to the judiciary. It is a fact that we, as politicians, as members of parliament, and the judiciary, belong to the most expensive medical aid schemes in the country, called PARMED. Where is an insult there? I mentioned it in public to the nurses for them to understand why we need to change this system. The Honorable Letlabe has actually presented a private member's bill. I don't know how far it is about this issue of PARMED. It is a fact that it is heavily subsidized by the state. It is a fact that those of us who are better off in this country are subsidized to be on private health care. That is not an insult to anybody. And the figures are there. It's not something that I'm guessing. And it is happening only in health, honorable members. When you go to the Department of Higher Education, people are subsidized through NEFSAS because they cannot make it. There is a means test to check who can pay for themselves or not. Those who can't are paid for through NEFSAS. When you go to the Department of Basic Education, schools are subsidized in terms of the capacity of the parents to pay. Those who are in very poor areas are called quintile 1 schools, the poorest, and they are subsidized more. Those who are in very rich areas are called quintile 5. They are subsidized less. When you go to the Department of Housing, Human Settlement rather, people are given RTP house because they can't build their own house. They are too poor to do that. When you go to SASSA, it's the same thing. But when you come to health, you must earn above a particular means in order to be subsidized by the state. Those are facts. Why can't we mention them in public? It is true in health we subsidize the rich. That fact cannot go away. It is true, yes, it is true that we subsidize the rich who form only 14% of the population, and the whole 86% do not get subsidy. It is true that that subsidy even becomes available when there's austerity. This year, or rather last year, when we could not even hire doctors, post-community service doctors, we went to Treasury to ask for more money, and because of austerity, it was not there. But 2 weeks later, I sat in a meeting called Mandating Committee where we increasing this subsidy to public servants, the subsidy of 70 billion, which has been increased just 2 weeks after there was no money to hire the others who are going to work in the public sector. So these facts are true. I was just mentioning them in public. I was not insulting anybody. Honorable Leroux, I got surprised when we say we can't even employ a fraction of post-community service doctors. I've just informed you that in the first 3 months of this year only, we employed 933 out of the 1,200 we've promised. The second thing you said, I'm not sure, Honorable Leroux, and I've always been worried about academics or health professionals in this country. And you are one of the health professionals. Of every day bashing Cuban healthcare system, I don't know for what reason. They've got results to show which we don't have, which Western countries don't have. Cuba has eliminated infectious disease like HIV, AIDS, TB, hepatitis, cholera, malaria. They are not there. They use primary health care to get rid of them. What problem are you having? They are the first country in the whole world which eliminated mother-to-child transmission. If it was a Western country, it was going to receive a Nobel Peace Prize. But they can't because they are Cuba. So we must give praise where it's due. Where they are wrong, we tell them, like I did in April last year when I was a speaker there about NCDs, because they do have a problem of smoking. We never praised them for that. We said, this is wrong. It's very wrong, this problem of smoking, because it increases non-communicable diseases. But where they've got rid of this, we must praise them. And please explain to me, Honorable Leroux, how can this strong private sector be subsidized by a weak public sector? And we regard that as normal. How can you suck blood from somebody who's poorer than you and be very proud of it? And for those parties here who call themselves left parties or black parties, I want you to take a stand. The medical aid system that started in 1967, you can count how many years, up to this time, covers only 10% of the black population, 10%. In this 14% who are benefiting from medical aid, when you look at the total population of black people, it's only 10% who are covered. How can we go on with that type of healthcare system? In the white population, of course, they've got something to defend because it covers 72% of their population. These are facts. It's not something I'm guessing. They are written down. You can go and check them. So why should we spare that type of a system? Nowhere am I going to stand here and reject that corruption is a problem. I want that money that has been stolen in Tembisa. But you can't use that as a reason why people can't get equity and universal health coverage. You can't use it. As money was stolen in Tembisa, in the public healthcare system, which is heavily subsidized, they tell us that 28 billion rand also disappeared. But they don't call it corruption or theft. They call it leakage. And black doctors were blamed for that. Black doctors who get only 5% of the total medical aid slice, they are the ones who were chased. If you look at the Section 59 report of Advocate Ngwaitobi, they were chasing blacks, and I was asking them, if you chase these people who got only 5% of the total slice, even if you get it back, what will you have helped? Because it means the money is disappearing to somebody else. But because it is stolen legally, through legal processes of the present system, we don't see it as corruption. We need to think very carefully, honorable members. Honorable Ghana, there's a little bit of confusion here. The 66 billion rand we are talking about here is budget for the national department. I didn't include provinces. If you include provinces, it's going to be much more. They are going to read it in their own legislatures. The one here is for the National Department of Health only. This amount that we are talking about today, because we are at the national level. So there should not be confusion about it. Honorable members, lastly, Dr. Letlape, please, Ntateman. Please, this issue of AI you have mentioned, me and you are in that profession. We know very well how the professions, if it was any other member who asked this question, I was going to respond to it. But because it's you, I'm not responding. No, I'm not responding because, no. I've got only 15 seconds here. I will get the time to tell you, there is nothing wrong in using AI to interpret X-rays. It's done all over the world. In fact, it has proven that their interpretation is even better than those of trained doctors. Where it makes a mistake is because you'll have clinical findings. You'll be able to compare what you see clinically and what you see on AI. I don't want to scare people off AI because it's one of the advances in technology.
Unfortunately, your time has expired.
Thank you very much. Thank you.
Order, honorable members. Members are reminded that two debates are scheduled simultaneously for 16:45 today. The Office of the Chief Justice, Budget Vote 27 in the Good Hope Chamber, while Statistics South Africa, Budget Vote 14 debate will take place in the Committee Room 46. That concludes the debate and the business for this mini-plenary session. The mini-plenary will now rise.
Recording stopped.